Thank you, Claire. So now we're going to go to a facilitated discussion. This is a really wide-ranging topic, and we thought it would be productive to, at least at the beginning of the discussion section, really focus on a couple of issues. So I'm sorry if I'm skipping over some of the questions that popped up earlier. But I think this is a good segue to the issue of de-identification and re-identification, which is really one of the hottest issues facing your field right now. All of the data sharing efforts, other than primarily one institution internal access, is not what we're talking about. So any data sharing, all of the open science efforts that we all support depend on data accessibility. But I wanted to let you know that there are some real storm clouds of public pushback starting to build regarding accessibility of data for open science and other purposes. This issue recently hit the public press, the popular press. So on July 23rd, Gina Colada published an article in the New York Times entitled, "Your Data Were Anonymized. These scientists can still identify you." And she talked about the report that Claire just focused on in her slides, which was a Nature article that proved that with certain algorithms, you could identify almost 100% of the American public out of heavily incomplete data sets, including data sets that did not include HIPAA identifiers. And the scientists decided to post their software code online for public use so that holders of de-identified data sets in the future could do a better job at protecting against re-identification of individuals. Keep in mind, too, that right now in the U.S., other than just a sampling of state laws, in the U.S. there is no present federal law that prohibits re-identification of individuals out of de-identified data sets. So currently there's very little protection for individuals coming out of the disclosure of de-identified data. And in the U.S., this is a concern because we have patchy healthcare coverage still. I mean, the hope of the Affordable Care Act is that every individual would be covered, but obviously that hasn't happened. So I think in places like the UK, where you have a national health system, and you don't have to worry about being denied health insurance, that's not an issue. Also in the United States, you have to worry about life insurance, disability insurance, and a whole host of other insurances that depend on health status. And so re-identifying individuals out of de-identified data sets where those data sets have rich clinical data about diseases or potential disease states through genetic information that those individual has is a big deal, and the public is starting to get concerned. And the scientific community, all of the supporters of open data and open accessibility of data, aren't doing a very good job at the public policy message that we have to get out, that we can't achieve these scientific goals without data accessibility. So at some point, we're going to have to figure this out. And in the meantime, I think as holders of de-identified data sets and in some of the open data efforts that are happening right now, I think there needs to be really close consideration of whether or not we need to start regulating who gets access to that data rather than having it open to the public as a whole. So that's what I'd like to focus the questions on. Magali.
Just wanted to clarify one point. You mentioned implications for insurance. What about employment laws? Are there any protections if an employer gets access to re-identify data and uses that data apart from the existing employment laws about, gender, da-da-da-da-da?
Right. There's a kind of a patchwork of laws regarding protection against employer use of that data. There's the Genetic Information Non-Discrimination Act, but it only applies to fairly large employers, not smaller employers. It also doesn't apply to someone whose genetic predisposition has actually manifested into a disease, just your genetic predisposition. There's ERISA, which governs the use of employer data, employer group health plan use of data. And then there's a variety of state laws that protect against individual discrimination. But it's a patchwork, like everything in the United States. So that's a real challenge for individual privacy. Yes, sir.
One other factor beyond personal One of the other aspects beyond personal privacy is actually the economic benefits of having this data. Let's say it's genomic data. We had a speaker here at the forum, Ed Yu, from the FBI, that really highlighted how this data, like especially genomic, can be used for economic profit.
Right, absolutely. Yeah, Ed Yu from the FBI is a really excellent speaker about the kind of national security risks around making genetic and other types of data, lots of data on Americans available. So he's a scary speaker.
Around the world.
Yeah, exactly. So one of the things I'd like to explore is if anyone has experiences with data sharing in research collaborations where you've seen good practices related to protecting against re-identification of individuals out of de-identified data sets. I think our goal here is to develop best practices to encourage open science and to protect individuals out of those open science efforts. Yes, Rebecca Lee?
Yes, so I lead an effort called VivLi, which is a global data platform, and so we hold data from both industry, large pharmaceutical companies who are, of course, very sensitive about their data. So we hold clinical trial data from industry, also from academic institutions like Harvard, Duke, UCSF, as well as nonprofit funders. And so when we think about this, we think about not simply one pillar of security, but multiple pillars of security that really help us with this protection of privacy. And the pillars of security we think about, of course, are our legal agreements as the first one, which is the data use agreement, and there is a clause for re-identification, but that is, of course, not sufficient, right? Because you can sign that and still go ahead and re-identify participants. The second one is we are a managed access platform, right? So you have to tell us who you are, and we manage that access, so you have to have specialized expertise. We do say that people do have to have statistical expertise to come into the platform. So that's the second one. And then, of course, for at least our platform, that the computation, by and large, has to be conducted within a secure enclave or within the platform itself, so within Microsoft Azure or our VivLi platform. I would say one, and then the data is also anonymized, so I would say that is another kind of pillar of security. It's anonymized. You've talked a little bit about the fact that that may not be sufficient, but I think that is another one. One we probably don't talk about enough, I think, is kind of the reputational risk that probably holds some people back. If I was to take a data set, I've signed the DUA, the data is anonymized, I'm doing it within this cloud environment, it's managed access. I do think, a reputable scientist probably would not put his or her reputation on the line to re-identify participants. But I think all those put together is kind of how we think about the package of protection of privacy, at least in our platform.
Great. Yeah, thank you for sharing that. I think one of the aspects to really explore is the concept of bringing the tools to the data versus allowing downloading of data, where all computation has to happen on a platform that holds the data sets, creating data playgrounds, for lack of a better word. Have there been challenges in using kind of the data playground concept with data sharing collaborations that we want to explore? Yes, ma'am. Can you restate your name first, please?
So I'm Elaine Appelmans. I'm working at the Foundation for the National Institutes of Health. And one of our goals is to bring researchers, both from private, nonprofit, and government, as well as institutions to our platform. And for the private partners, some of their interests are they have data in their own environment, and therefore they need to download that data because they can't share that back to the platform. Mm-hmm. So if they have clinical trial data that they can't share, then they can download our data and work with that in combination with their data.
Right. So Claire, one of the things that you mentioned in your program is talking about how some of the data governance occurs at the actual clinical trial level. where the individual consent that was obtained for obtaining data through a clinical trial or a biobank program may dictate whether or not you can share your data. Do you want to expand on that?
Yeah, and in fact, I didn't explain very well that the model that you've just described, was it called Vivek? Vivli is exactly the one that we're using for the Dementias Platform UK. So that's the basis on which the individual cohort owners are prepared to share their data. In this model, is that it's not possible to download data from it. So it's a place where data, it's a safe harbor for data, and analysis comes to the data rather than the other way around. So as individual cohort owners, that's a lower barrier. That's a safer basis on which to share data than just allowing downloading generally.
So on the issue that Emily brought up, that the individual that the individual institution may not have the legal ability to bring their data to a platform that has more controlled access. Are there any ideas around the development of best practices to guide the content of informed consent for clinical trials or participation in biobanks or repositories to ensure that individuals do consent to sharing their data with larger data sharing collaborations or platforms?
I would
Yeah, Deanna?
emphasize that seems like a really important contribution that this forum could make is to try to say what we need is sort of best practices in consent forms of different type, so that people are very, because I think we need to make a distinction between data already collected, where we may or may not be able to change under which it was consented, versus going forward, how can we optimize consent forms to make sure that participants understand their rights and privacy, but consent to as many possible uses. And so, again, I think in terms of practical solutions, if we could convene some working group to kind of recommend best practices that might either be, U.S. versus Europe or some combined things, so that we can optimize that going forward. Because we've all been bitten in the tush by not having had that in your consent form and then not being able to go back and reconsent participants for that kind of usage.
That's right. And the NIH has done some of that template language development. For example, they have template language regarding sharing genome-wide association study information through the GWAS database. So I think there's good practices to follow to actually develop template-informed consent language, at least for clinical trials and research repository participation where there's consent. You're right that there's a big distinction between existing clinical data that's collected for clinical care. That's kind of a different way of handling the consent.
Well, but even for clinical care, presumably there are consent form issues going forward that you could modify what the consent looks like to ensure that, versus data that's already been collected and we kind of can't change necessarily what they've consented to.
Although from the health system perspective, the big institutional providers, generally consent is not required to collect the information, and sometimes there's other prohibitions on putting too much in that consent form. So typically you don't include the consent to use for research in the consent to treat form, which is what the healthcare providers are focused on. But we should tease those things out in developing those best practices. Yes, sir.
I think just beyond just developing best practices, some other part is mechanisms for implementation. So, for example, years ago there was an NIH workshop where we all recommended, okay, even though people aren't sharing, it should be that everyone is putting sharing language in the consent form, so that if the day comes for sharing, that they would do that. And something like that was never quite actioned. If it was that any federally funded or research automatically had to have that language in there as part of the agreement with NIH or any others, that would make a big difference as far as preparing for what Deanna's saying. Because right now we know the range of use cases, and the researcher doesn't view it as that's ever going to be a use of their data, but that's not necessarily true. But they are guaranteeing it won't be use of their data by not getting the consent. So if the funding agencies would actually put requirements like that, it's not overly laborious, and it would actually be very impactful.
That's right. That's a great idea.
Here.
Yes, Magali?
Sorry, I just wanted to build up on your idea of the working group, that in addition to the best practices around consent forms, What I've heard across the different presentations are perhaps different definitions of what is a qualified researcher and how are they defined. I've also heard different definitions of what constitutes sensitive data. So, on the one hand, it's open, and on the other hand, it's sensitive, and there don't seem to be universal rules. So I would sort of package those things together.
Right. Yeah, so pursuing kind of that theme about developing access controls, that's one of the things that came out as a best practice versus, full public access. Any best practices around defining who should have access to data sets? Does it matter who holds the data set, what kind of data is in the data set, et cetera? So any best practices that people want to share? Or questions around what you think should be in those best practices around access control?
I'll just say, one of the big debates, I've been involved in several different consortiums that have taken different approaches, right? So the original Human Connectome project had anybody in the world, didn't matter who you were, could download the non-sensitive data. Whereas going forward, ABCD and other consortiums that I'm involved in are all using data use agreements that are much more structured. I guess I would say, as much as I hate to say it, and if Russ is on the line, he'll probably rain down wrath of God on me. I think it's getting increasingly hard to do a completely open data access without any evidence of qualified researchers. And, I guess I'd want to know, is there any really true downside other than the practical effort? I mean, it requires more control to kind of that being a best practice recommendation going forward, that there probably does need to be a data use agreement. There does need to be some evidence that the person has a legitimate interest in doing this, and some recourse should they violate the data use agreement. So part of our logic had been, if they are an investigator at an institution and they violate the data use agreement and try to re-identify, that actually violates their institution's principles, and you can actually go back and there's consequences for them. Whereas if it's my grandma and she violates the data use agreement, like, there is no consequence for that, right? Like, currently, I mean, but it's true, like, anybody could download it. And so, is that too restrictive, or do we want to kind of recommend that may have to unfortunately be the pathway going forward?
Yeah, feedback on that? Feedback on that point?
Yeah. If you're doing a big data analysis of certain genes or polymorphisms with their electronic health records, there's really no need to have that granularity of the data of the individual. So keeping it like in a federated data set of databases where you can query them for that information, it requires people to be sort of on similar platforms to access all that data to query it. But you're not downloading it, so you're not violating you're not having a chance of de-identifying the people in there.
But saying that, I mean, that may be true for some platforms, but we are nowhere near close to being in a situation where.
That should be a goal then.
Well, it could be a goal, but it's not going to be a tomorrow goal, right?
Exactly.
Yeah.
One of the really great efforts happening right now that you're probably familiar with is the FDA Sentinel Initiative. I've been working with them for a number of years on the privacy protection rules around that, and they decided to pursue a federated data model where all of the institutions, both health systems and health insurance companies who are participating, have to put their data into a common data model, which is quite work intensive. So you're right that there's a barrier there with creating the resources that do that. But once you create a federated data set with a common data model, you can do pretty powerful research spread across different databases. So there you bring the tools to the different data sets versus one data set. That also solves the problem with some institutional control problems, because some institutions don't want to give up their data. And so participating in a federated data model set may be another option versus singular platforms that house everybody's data. You have a follow-up on that? Okay. Yeah, what's your name first, please?
Mike Milham.
Oh, that's right.
And personally, I think that on the one hand, I shared Diana's concern as far as where to draw the line. And one of the speakers earlier had mentioned fMRI and identifiability. You don't need fMRI, just use the structural image. Any imaging data set, if I have the structural image, I'll go and have a pretty good idea who that person is in that open data set. So on the other hand, to get the structural image, that's a whole other thing in order how to do it. But I think one of the things with these decisions about where to draw a line for open versus not is also determinations of risk. So for example, with some of our data sharing initiatives, what we've done is we've had the light version where there's a structural image, defaced, age and sex, and that's what's available publicly for anyone without a data usage agreement. It keeps a spirit of openness. It is inviting to folks. And you could put some bare minimum information there and not worry, but then all the high dimensional information, clinical, we then go and put that behind a data usage agreement. If you look at something like Open Neural, a lot of those data sets are all just cognitive tasks. They're not phenotypically rich. If data is not phenotypically rich, what are you really going to learn about an individual? That they're male and what their age is? That's not real risk. So I think these kind of determinations, because the risk, going to Diana's point as far as what is the risk is just the massive overhead that could be put in terms of data usage. Also, it could be dissuasive, and also use it, for infrastructures. For people who are like, how am I going to get a data usage agreement? My institution's not going to support me in this. I mean, it would take a lot more infrastructure to be put in place to have that be widespread. But I do think there also needs to be discretion as far as what's the risk for a given data set if there was re-identification.
Yeah, Magali?
So I'd like to just throw out a sort of a case study question also for you. So it's something we're wrestling with actively as we're building out the Brain Commons, which is a deep phenotype, genomic imaging, every kind of data set is there for individuals. And then and it is a controlled access environment, but now authentication and all of that, within the United States, you can have a higher degree of confidence that you know who these individuals are. They're at institutions that we know what they are in turn and so forth. What about the rest of the world when they want access to these data sets? Global, when it's UK, fine, you know where, but what about certain other areas where we have concerns and maybe security concerns and other concerns? How do we handle that?
Any ideas?
What is the concern?
That's a huge challenge. Go ahead.
So maybe, and so at Vivli, we do have researchers, and maybe I can just tell you what we do. We do have a number of researchers outside the U.S., primarily the U.S. and Europe. Probably 60% of the researchers coming into Vivli are U.S. and Europe, but the rest is rest of world. And so how we do manage this in a managed access perspective is we do require a research proposal, and we do require expertise. I mean, just like you mentioned, and there was initial discussions in terms of governance, and the major pushback should patients have access to this, right? Your grandma or your mother-in-law should, these types of people, because they may be participants, should they have access? But we did, all of our stakeholders, including our members, did feel like there should be expertise, and the expertise that we honed in on was that there needed to be someone with statistical expertise on the team, and that was really where we pinpointed so if your grandma had someone with statistical expertise that was documented on the team, that would be okay. That would be fine. And so that's where we kind of had, a stake in the ground that they needed to have statistical expertise. It doesn't have to be a PhD in statistics. It could be an epidemiologist, and that would be where we would have demonstrated statistical expertise on the team, and then they could have access. Mm-hmm.
So you're talking about a highly manual process where every single individual is, their application is reviewed, and you're making some kind of assessment, and you know where they're coming from.
Correct.
And what university and so on.
So even if it was, Joe Brown, and then he has a statistical expert on his team, even though we don't know if he does have a statistical expert on the team. He might be a patient advocate, for example. We would allow him and his team to have access to the data because he has a statistical expert on his team.
One thing to
the clinical trial data. Yeah.
I'm sorry, I didn't mean to interrupt you. One thing to keep in mind there too is that then you're regulating the institutional access, and that's a big distinction that everybody has to think about too, is whether you're going to allow an individual person who may meet your qualified researcher category to sign a data use agreement, whether that's enforceable or whether you need to have the institution that investigator works for sign the data use agreement, which is much more enforceable. We still haven't gotten to the really tricky issue about where data actually flows to another country, how you regulate that access. At Vivli, you have a research platform that you control. The researchers come to the data, which is held by your platform. So that's a safer way to allow open access versus allowing people outside the United States or outside the EU to download data sets for their research. In part, one of the things you need to layer on top of this, too, is as Bill had mentioned in his talk, there's a huge number of data attacks going on in both healthcare institutions, but also our National Security Administration, et cetera, largely based out of foreign countries who are downloading, basically stealing huge data sets for purposes of identity theft and spoofing Medicare claims and a whole host of other kind of financial crimes, including proprietary information. So allowing free downloading of clinical data sets, even if de-identified, could actually be being done by individuals who don't have good intentions. So vetting who has access gets more challenging when it's the individual versus the institution, and gets more challenging when it's outside the country where the data is held. So, yes, did you have a...
Hypothetical situation. Say you run a clinical trial, you find that when you stratify the data at the end, that there is a population of a certain phenotype that strongly benefits from a drug. But you don't have enough there to really prove it. There's a big database that has everybody's phenotype, wherever that, and you see that there is a connection with this phenotype in that same disease situation, and these people might be able to benefit from that. If you had a way of the patient who's in that big database to say, I want to be re-identified for any treatment, how would you then give that person access to care? Sort of like what was sort of brought up earlier,
Right.
without them being de-identified for someone who may not have their best interests in mind.
Right. I think, there's probably a variety of answers and different ways to approach that problem. It probably would depend on who holds the data and what circumstances the data were collected under. If it was part of clinical care, so it's housed in an electronic health record database, it's a different situation than if it's a clinical trial data set and you have found some kind of correlation with their potential participation in a different clinical trial, for example. So I think how you approach that issue depends a lot on who holds the data and how the data was collected. Not much of an answer. Who knew healthcare was so complicated?
Can I go back to Mike, your point? I'm trying to think about the practicalities here in terms of like neuroimaging data. Like how, you said you thought there are going to be people who are at institutions where their institutions couldn't or wouldn't support them in developing a data use agreement. How often do you think that occurs? Is it a lot? I think I'm biased by being at a big R1, and so I don't know if I have a good sense of. I'm
talking about really the smaller data sets. If you think about it, unless the institutions really put a mechanism in, then for researcher after researcher to be saying, I'm going to now share my data, what is it? The institution would need to make the investment. My impression is institutions are somewhat variable, and if you think about it, you're going through your grants and contracts office and so forth, which that is a pretty significant. I mean, for some of our efforts that we've done, like where I was doing it out of for NKI, the Nathan Klein Institute is a state psychiatric institution. So there, in order for me to put together paperwork with institute, we had to actually go through all the multiple levels of New York State lawyers and so forth in order to deal with it. For depending on what your institution setting, that could be quite difficult or not. And the smaller settings aren't going to have the resources. And I do think it's just a matter of figuring out, there needs to be a balance. So it is figuring out what's really needed, and because for some work that you would look at it and say, do you really need a data usage agreement? So like someone wants to do a small psychological experiment with no phenotyping, but it's imaging data, and that's a value. But I do think that'll A, give folks an excuse not to share, frankly. B, institutions will sit there and have all sorts of pushbacks. as far as the number of investigators coming, unless the institution is prepared for that. And I mean, but if everyone actively tried to share. On the flip side, you might not have much takers, so it's not a big deal.
But is there a distinction between I have data that I want to give to a repository to share versus people who want to go to a repository and get that data, right? So can we make that, because that seems like those could be two separate issues, right? Because like in terms of like if you're in the US, NIH or NSF funded, or maybe MRC or Wellcome in the UK, there's a requirement for data sharing, right? So we have to solve that issue. But from the perspective of like ENDAR, right? So ENDA, right? They require a data use agreement from everybody. And does that help to kind of address some of these protection of privacy issues?
I still would say, so for example, for NKI Rockland Sample and for a Healthy Brain Network, in both of those we have data usage agreements. We put some bare minimum out, first of all, as a teaser to the community. It really does help a lot from that PR perspective, from not having folks say, oh, here's another one, and what are they really going to do? And on the flip side, I don't think there's much damage in that. Because
in the very restricted data set.
Yeah, exactly. So, I think that's a good faith gesture, which for some folks, that's all they actually really need, because they're doing a lot of methods development, and they really don't actually care about any of the other. So I just think it's that kind of balance, and we've really tried to do the model of here's the bare minimum to, that you can't get yourself or us in trouble with, and then here's the rest now for that, go to pre-use.
And that was the original HCP model, too.
And I think Claire has a remark. And then are we supposed to break for lunch? What time does lunch start?
Yes.
At noon? Okay. So Claire, and then I guess we'll break for lunch, and then we'll be back to report on all of our conclusions.
I just wanted to follow up on that with the observation, really, from the conversation about how we're all juggling multiple influences as we're making our decisions about how and when to share data, and the particular one about the institution versus the funder. It's kind of actually, obviously, the institution has more of a concern about being fined, so the risk aversion is greater from the institution. The funder is very keen to promote the sharing, and then the third of the in that triangle is the field, and that's us. We're all here because we're neuroscientists. We're not representing a funder or an institution, and so somewhere in between that, and we've all got to kind of take the individual use case of the data set that we're working on and figure out and I suppose that back to the idea of having some kind of a working group, it's almost like what we need is a self-help group, so that we can work through the individual, because there are no principles that work in all cases, and that was kind of what my talk was designed to point out, that there isn't going to be a solution that's going to work in every instance, but having a community of people where we can go and get support for the individual use cases is probably something that I would find particularly useful.
Can I ask a follow-up question to Bill on that? So it seems like Penn is doing a tremendous amount of work on trying to work through these issues. So is Penn getting together with Harvard or MGH and also blah, 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 and saying, okay, instead of all of us reinventing the wheel, are there commonalities here that we can share out to all these other institutions?
I would say no, but, it's interesting that you should bring that up. There are 2 or 3 recent, and you're probably all aware of this, Google in Chicago, NHS and DeepMind, Mayo and Google, large collaborations where they're either proposed or they've already gotten into situations where there's a lot of pushback. And there's a JAMA position paper, which I was trying to find, and I will get this out, that speaks to the need for data governance principles in these collaborations, and I think that's important. I think we feel like we're in the vanguard of having these discussions. Really, it's in a sense it's reactive because of this. It probably seemed right-minded to the principals involved in these prior collaborations to do it, but then you realize you're working with partners that are very skilled at re-identifying. I mean, there's risks associated with the primary relationship and then any secondary relationship, which goes to the problems that Facebook have gotten into with Cambridge Analytica, where they're downstream consumers. And we've had situations where we've shared data with a startup, the startup got acquired, we lost control of the data. I mean, these are the kinds of things that need to be thought through. And so I would say Not as of yet, but that would be a good outcome of this meeting. And I will share that JAMA position paper.
That's great. Well, thank you for the great discussion. See you back after lunch. Thank you.